Welcome to another lesson as we cover asthma. Asthma is a chronic airway disease that causes bronchiole airflow blockage that is intermittent and reversible. Inflammation or airway hyperresponsiveness causes the blockage. Asthma can strike anyone at any age. The reason behind this is unknown. Mucosal edema, bronchoconstriction, and increased mucus production are all symptoms of asthma. Promotion of health and prevention of disease. If the patient smokes, encourage them to quit. When working in surroundings with carcinogens or particles in the air, advise the client to wear protective equipment, a mask, and provide sufficient ventilation. Vaccination against influenza and pneumonia is recommended for older persons and all asthmatic clients. Instruct the client how to recognize and avoid triggering agents. Triggering agents are the following: environmental factors such as changes in temperature, especially warm to cold, and humidity, air pollutants, strong odors, perfume, seasonal allergens, grass, tree, and weed pollens, and perennial allergens, mold, feathers, dust, roaches, animal dander, foods treated with sulfites, stress and emotional distress, medications, aspirin, NSAIDs, beta blockers, cholinergics, enzymes including those in laundry detergents, chemicals, household cleaners, sinusitis with postnasal drip, viral respiratory tract infection. Teach the client how to self-administer medications, nebulizers and inhalers. Educate the client regarding infection prevention techniques. Encourage regular exercise as part of asthma therapy for the following reasons. It promotes ventilation and perfusion, maintains cardiac health, and enhances skeletal muscle strength. Clients may require pre-medication. Instruct the client to use hot water to eliminate dust mites in bed linens. Assessment. The diagnosis is made based on the findings and is divided into 4 groups. Mild intermittent, symptoms occur less than twice a week. Mild persistent, symptoms arise more than twice a week but not daily. Moderate persistent, daily symptoms occur in conjunction with exacerbations twice a week. Severe persistent, symptoms occur continually along with frequent exacerbations that limit physical activity and quality of life. Risk factors. Older adult clients have decreased pulmonary reserves due to physiologic lung changes that occur with the aging process. Older adult clients are more susceptible to infections. Beta-adrenergic receptor sensitivity declines with age. Agonists, which relax smooth muscle and cause bronchospasms, are less able to respond to beta receptors as they age and lose sensitivity. Family history of asthma, smoking, secondhand smoke exposure, environmental allergies, exposure to chemical irritants or dust, gastroesophageal reflux disease, GERD. Expected findings during assessment: dyspnea, chest tightness, anxiety or stress. Physical assessment findings: coughing, wheezing, mucus production, use of accessory muscles, prolonged exhalation, poor oxygen saturation, low SaO2, barrel chest or increased chest diameter. Obtain history regarding current and previous asthma exacerbations. Questions you will want to ask the patient are the following: onset and duration, precipitating factors, stress, exercise, exposure to irritant, changes in medication regimen, medications that provide relief, other medications taken, self-care methods used to promote relief. Laboratory tests: arterial blood gases, hypoxemia, decreased PaO2 less than 80 mm of mercury, hypocarbia, decreased PaCO2 less than 35 mm of mercury early in attack, hypercarbia, increased PaCO2 greater than 45 mm of mercury later in attack. Sputum cultures, bacteria can indicate infection. Diagnostic procedures: pulmonary function tests, PFTs, are the most accurate tests for diagnosing asthma and its severity. Forced vital capacity, FVC, is the volume of air exhaled from full inhalation to full exhalation. Forced expiratory volume in the first second, FEV1, is the volume of air blown out as hard and fast as possible during the first second of the most forceful exhalation after the greatest full inhalation. Peak expiratory flow is the fastest airflow rate reached during exhalation. A decrease in FEV1 by 15% to 20% below the expected value is common in clients with asthma. An increase in these values by 12% following the administration of bronchodilators is diagnostic for asthma. A chest X-ray is used to diagnose changes in chest structure over time. Nursing care. Position the client to maximize ventilation. High foulas. This is frequently asked on many exams. Administer oxygen therapy as prescribed. Monitor cardiac rate and rhythm for changes during an acute attack. Can be irregular, tachycardic, or with PVCs. Monitor respiratory rate and rhythm for changes in effort, symmetry, SAO. Auscultate lung sounds. Initiate and maintain IV access. Remain calm and reassuring. Provide rest periods for older adult clients who have dyspnea. Design rooms and walkways with opportunities for rest. Incorporate rest into ADLs. Encourage prompt medical attention for infections and appropriate immunizations. Administer medications as prescribed. Medications. These main medications used are bronchodilators, which are inhalers, and anti-inflammatory agents. First, we will go over bronchodilators, as there are different types, which are the following. Short-acting beta-2 agonists, such as albuterol, provide rapid relief of acute manifestations and prevent exercise-induced asthma. Anticholinergic medications, such as ipratropium, block the parasympathetic nervous system. This allows for the sympathetic nervous system effects of increased bronchodilation and decreased pulmonary secretion. These medications are long-acting and used to prevent bronchospasms. Methylcanthines, such as theophylline, require close monitoring of blood medication levels due to a narrow therapeutic range. Use only when other treatments are ineffective. Long-acting beta-2 agonists, such as salmeterol, primarily are used for asthma attack prevention. Nursing actions. For albuterol, watch for tremors and tachycardia. For ipratropium, observe dry mouth. For theophylline, monitor blood levels for toxicity. Adverse effects include tachycardia, nausea, and diarrhea. Client education. Ipratropium. Suck on hard candies to help relieve dry mouth, increase fluid intake, and report headache, blurred vision, or palpitations, which can indicate toxicity of ipratropium. Monitor heart rate. Salmeterol. Used to prevent an asthma attack and not at the onset of an attack. Anti-inflammatory agents. These medications are for prophylaxis and are used to decrease airway inflammation. Corticosteroids such as fluticasone and prednisone, leukotriene antagonists such as montelukast, mast cell stabilizers such as cromolyn, monoclonal antibodies such as omalizumab. Nursing actions. Watch for decreased immunity function and wound healing. Monitor for hyperglycemia. Observe for fluid retention and weight gain. This can be common. Monitor the throat and mouth for aphthous lesions, canker sores. Omalizumab can cause anaphylaxis. Client education. Report black, tarry stools. Drink plenty of fluids to promote hydration. Take prednisone with food. Use these medications to prevent asthma, not for the onset of an attack. Avoid people who have respiratory infections. Use mouthguard care and hand-washing regimen. Do not discontinue medication suddenly. Perform daily peak flow meter assessments. If only able to achieve a reading in the red zone, immediately use the reliever medications and seek emergency care. The next type of medication to cover are combination agents, which have both actions of a bronchodilator and an anti-inflammatory agent. If prescribed separately for inhalation administration at the same time, administer the bronchodilator first in order to increase the absorption of the anti-inflammatory agent. Examples of these medications are ipratropium and albuterol, fluticasone and salmeterol. Care between professionals. Respiratory services should be consulted for inhalers and breathing treatments for airway management. Nutritional services can be contacted for weight loss or gain related to medications or diagnosis. Rehabilitation care can be consulted if the client has prolonged weakness and needs assistance with increasing level of activity. Complications of asthma. Respiratory failure. Persistent hypoxemia related to asthma can lead to respiratory failure. Nursing actions. Monitor oxygenation levels and acid-base balance. Prepare for intubation and mechanical ventilation. Status asthmaticus. This is a life-threatening episode of airway blockage that frequently does not respond to standard treatment. Extreme wheezing, difficult breathing, the usage of accessory muscles, dilated neck veins, and a danger of cardiac and/or respiratory arrest are all symptoms. Nursing actions. Prepare for emergency intubation. Administer IV fluids, oxygen, bronchodilators, and epinephrine. Initiate systemic steroid therapy. That ends the lesson on asthma. Check out our other nursing videos to help make studying easier. Also, see below for useful links that take you to NCLEX-style quizzes, nursing study guides, and more.